morning, Sawasdee krab. In this sessions, I'm talking about the pharmacogenomics testing on HLA to prevent scar severe cutaneous adverse drug reactions in Thailand. I would like to update you on the research, health policy, and also the clinical practices in our country. First, thank you for the organizing committee and also Dr. Pavini for inviting me to share my experience and also knowledge in this conference. I have no conflict of interest to this presentation. All of my talk today can be searched and read through this review article which published recently. So in these sessions, I would like to focus on the current situations of the pharmacogenomics and precision medicine for prevention of severe cutaneous adverse drug reactions in Thailand. I'm going to talk briefly the Genomics Thailand project, update you the national health policy for pharmacogenetic screening tests to prevent the scar in our country, and lastly, the clinical implementations and my experience of pharmacogenomics and precision medicines in our setting will be sharing to you today. As you may have heard that Thailand has launched the mega project as Genomics Thailand project. We would like to establish the whole genome sequencing database for 50K sample of Thai populations, which can be recruited from 5 areas such as cancer genomics, rare diseases and pregnancy women, non-communicable diseases, infectious diseases, and also the pharmacogenomics. We aim to use the genomics technology to drive our healthcare system for our country to take care our people in the near future. As the pharmacogenomics can be applied into many disciplines, one of that is the pharmacogenomics of the SCAR. For the pharmacogenomics of Thailand, we aim to transfer our knowledge from research into clinical implementations as two approaches. First one is the pharmacogenomics study of drug dose adjustment, and the second one is to discover the biomarker for prevention of scar in our Thai populations. For the pharmacogenetics of scar, HLA gene is very important biomarker since it can be translated to be the HLA protein which expressed on cell membrane, as you may see in the figure. The drug molecules such as carbamazepine in this figure can be presented to T cell receptor for activation of the immune system, as you may see. After that, the inflammation process can be occur throughout the patient's body, inside and outside, as you may see in the clinical manifestation of the scar. Here, I have updated and summarized the pharmacogenetics biomarker to prevent the scar for Thai populations. As you may know that HLA-B 1502 has been announced to be the national policy screening before carbamazepine treatment. So it can be applied for selecting the oxcarbamazepine as well, because carbamazepine and oxcarbamazepine share the risk marker alleles together. And in this year, the HLA-B 5801 has been launched as a new screening test with a national policy screening before allopurinol treatment in our country. Recently, we already discovered the potential biomarker for Co-trimoxazole and dapsole, which is HLA-B 1301. As you may know that the co-trimoxazole is the most common culprit drug for scar in Thailand. So we are now put our effort to propose this biomarker as a national screening test for co-trimoxazole and dapsole preventions by initiating the cost effectiveness analysis right now. One of the key factors for the economic evaluations to convince the healthcare policymaker is the high frequency of risk and real in such populations. So from here in this figure, you may see that the Thai population is a high risk population for scar, as same as for the Southeast Asian community, since we have a very high frequency of risk and real throughout the regions. And in this figure, so in Thai populations, about 16% carry HLA-B 1502 for carbamazepine, 15% for HLA-B 5801 for allopurinol, 13% for HLA-B 1301 for dapsole and co-trimoxazole. Therefore, the Thai population has a very high risk of severe cutaneous adverse drug reactions. So the national policy screening of HLA is very important to prevent the adverse events and eradicate the scar in our populations. So here is a track that should be followed if we would like to push our research finding into the clinical implementations as a national policy. So therefore, we get the HLA-B1502 as a national policy for 10 years, starting from the retrospective study to discover, validate, and also confirm the association in Thai populations. Then move into the next step for economic evaluations analysis, and then perform the prospective screening study as a pilot project in Bangkok. At the same time, we develop the local and also international guideline, and all informations and readiness will be packaged to submit to the healthcare policymaker to consider and approve to be the national policy screening test in 2018. So that HLA-B1502 is the first biomarker that has been approved and announcement in 2018 to prevent the scar in patients who are going to treat it with the carbamazepine in any indications. However, the serotype 75, such as HLA-B1521, should be considered for the clinical implementations in some testing, especially in Southeast Asia, and I will show you the evidence later. Moreover, the biomarker for carbamazepine has ethnic specificity, so therefore the HLA-A3101 has to be considered in some private hospital setting in Thailand because they are the setting to take care of foreigner patients and sometimes take care for the mixed children between Thai and also Caucasians, Japanese, and also Korean in our country. This is an example of the report from American patients who visited to my clinic and show his result for asking the appropriate drug for his neuropathic pain status during the admissions. So we would like to prescribe carbamazepine, but when we consider for the result that they carry from the America, so we found that carbamazepine has to be avoided for prescription in these patients at all. Even he got negative for HLA-B1502. But when you look into the report, you may see that he got the positive for HLA-A3101, which is a specific biomarker for Caucasians. As I already mentioned about the serotype 75, by this case report from Thai patients, we demonstrated that the biomarker for carbamazepine screening is not just only for HLA-B1502, but we have to consider for a serotype 75 as well. Since in this case, he was negative for the HLA-B1502 and received the carbamazepine for treatment at that time. So after that, he came back to the hospital with carbamazepine-induced Stevens-Johnson syndrome. So what happened in these patients? When we did the HLA-B genotyping for him, so we found that he carried the HLA-B1521, which is the same family of HLA-B1502. Therefore, we also demonstrate by the in silico model that HLA-B serotype 75 not just only for 1502, but also HLA-B 1508, 1511, and 1521 can present the carbamazepine molecule to T-cell receptor and activate the immune reactions in the patients. So these associations was found and confirmed in other Asian populations such as in Indonesians, in Filipinos, and also in Japanese. So right now, in the laboratory, we concern in this point and provide a variety of testing for screening of the high-risk SCAR patients. The test can be delivered at different information level to our physicians to make the decision for their own patients. One is a specific biomarker screening test, and in this test is supported by National Health Security Office of Thailand, also PSOCHO. And this test just only test for a specific biomarker and show positive or negative only. By the second test is the test for HLA-B genotyping, and the physician can see the genotype of the HLA in that patient for the both alleles. And this test can help to rule out the carrier for HLA-B serotype 75 for carbamazepine treatment as well. And we also provide the panels of HLA-A and HLA-B genotyping to serve for Caucasians and foreigner patients, and mixed children between Thai and also Caucasian, Japanese, and also Korean in our Thai country. So recently in this year, the HLA-B 5801 is also incorporated into the national policy screening test in patients who are going to receive the allopurinol in Thailand. So the patients who are positive for the HLA-B 5801 will be treated with flipurostat as an alternative choice, since this drug is in the national drug list as a conditioning use category. So therefore, the HLA-B 5801 positive should be the condition to indicate the patients who are the high risk of scar from allopuriноls and needed to prescribe flipurostat instead of allopurinol in these patients. So right now, we also demonstrate in Thai study that not just only for the genetic predisposition factor for scar, but also the non-genetic factor such as allopurinol dose and also renal impairment status that can be a predisposition factor for allopurinol-induced scar. In 2020, the American Rheumatology Guideline has recommended to start the allopurinol with lower dose, like less than 100 milligram a day, especially in renal impairment patients like chronic kidney diseases. Last year, we also first discovered the biomarker for co-trimoxazole-induced stress, that is a HLA-B 1301, showed a strong association for co-trimoxazole-induced stress, but not for Stevens-Johnson syndrome and TEN in Thai populations. This is the first time to demonstrate that the biomarker for co-trimoxazole has phenotype specificity because HLA-B 1301 shows strongly association just only for DRESS but not SJS and TEN, as same as for the HLA-B 1502 for carbamazepine, which is show the strong association with SJS TEN only for carbamazepine but not for DRESS. So the HLA-B 1301 has been confirmed the associations by whole genome sequencing in more sample size and various populations, such as in Han Chinese in Taiwan, in Thai patients, and also in Malay. And in this study, also show in computer model that not just only for sulfamethoxazole, but its metabolite of sulfamethoxazole can be a trigger of immune system to initiate the scar in the patients. Surprisingly, the HLA-B 1301 also show association with dapsone in Asian populations, such as in Chinese, in Thai, and Indonesians. And interestingly, we first characterized the phenotype non-specificity for HLA-B 1301 in dapsone-induced SJS, TEN, and also DRESS from dapsone, which is look like for HLA-B 5801 for allopurinols that show the strong association with all spectrum of scar from the allopurinols. Recently, we also confirm with the association with the more sample size and also demonstrate in the figure that show you here that not just only for dapsone, but also its metabolite can form the bonding with HLA-B 1301 and present to T-cell receptor and trigger the immune system by its silico models here. And as you may already see by the tables that I summarized previously, most of the pharmacogenetics biomarker for SCAR are on the HLA-B genotyping. Therefore, it allows us to deliver the panels for interpretations and make the report as a panel prediction if we perform the HLA-B genotyping, which is superior for the HLA-B genotyping than the HLA specific testing. So the HLA-B gene is in the germline genes. Therefore, the individuals who genotype for HLA gene in once in a lifetime. From this concept, their data can be remained into the electronic medical record and update for the whole life of individuals to save them for the future drugs as well. Unfortunately, even we have the national screening, but we lost our patients from our experience for the carbamazepine-induced TEN when we explore in this event, we found that we lack of key things in the clinical implementation at that time. So the key success for clinical implementation to prevent the patients very successful is we lack of health professional awareness. We have no electronic medical record at that time, and we have no counseling system to alert the patients and also physicians as well. Therefore, nowadays, the electronic medical record has been enhanced to set up to alert for the doctor when they would like to order a high-risk drug, such as abacavir, carbamazepine, and also allopurinol, even they have no awareness or have no knowledge. This alert system can help to prevent the patients by alert to the patient to order the pharmacogenetic testing before prescriptions. Moreover, when the lab is already done, the pharmacogenomics result will be incorporated into the electronic medical record in the setting to alert and pop up the positive result for the physician and also pharmacists. They have to consider to avoid the prescriptions of the high-risk drug in that patients who are positive result. Moreover, the pharmacogenetic counseling system have to be integrated into the precision medicine workflow, as shown here in this figure. The pre-test counseling and post-test counseling of the pharmacogenomics has been integrated in the setting for a precision medicine workflow here. So the counseling system can be operated as a personal pharmacogenetic counseling. We can use this opportunity to deliver the pharmacogenetic card and also the precision medicine result to the patients. And we also let them know that what their own risk and which drug that should be avoided in their future life in these times. So currently, as the COVID-19 outbreak and it's getting worse situations in our country, the telemedicine or telecounseling has been set up accordingly. In this system, we can counseling remote for the patients who are inconvenienced to come to the hospital since they may scare to the COVID-19 exposure during the traveling. As I mentioned that the Genomics Thailand is the national agenda or related public health council, such as Council of Pharmacy, Council of Physicians, Council of Dentistry, Council of Nurse, and Councils of Medical Technology join together to develop and prepare to develop the human resources in our country and join together to develop the training course for a genetic counselor. And specifically for the pharmacogenetics testing, the Pharmacy Councils of Thailand also prepared a training course for a pharmacist who will be in charge for pharmacogenomics in clinical implementation. As the lack of health professional awareness, we also provide a workshop, academic meeting, and also conference to provide the knowledge and enhance their awareness throughout the country. So however, in the real world, in the clinical practices, the patients may take care by several doctors, not just only one doctor, and they may receive not just only one drug, but they may get polypharmacy. So we are now implementing the panel pharmacogenetic test in some setting, and you may see how complicated in this polypharmacy of this patient. And sometimes the patient may take herbs and also food, which is interact or interfere with the clinical outcome in that patient that we have to take into account for consider of the drug of choice in that patient. So therefore, right now, we are now developed the clinical decision support tool for complicated condition like this. So in the real world, not just only for drug and gene that have to be considered for drug of choice in the patients, but we need to consider for a patient condition like liver function or renal functions, and also sometimes we have to consider for food or herbs in that patients that maybe interact with drugs of pharmacy in that patient, and let the doctor know that which drug that can be prescribed safely and which drug should be precaution and which drug should be considered as an alternative choice for that patient to prevent the adverse events. And so this is a 10-year data for my labs So you may see that the number of requested pharmacogenetic screening for SCAR has been increased year by year. On the other hand, the incidence of HAS antigen has been decreased year by year as well. And when you look into the pie chart here, you may see that half of the requested is from public hospital and another half is from private hospital. And the most common requested for the physician is HLA-B 50X01 for allopurinol screening. And so in the near future, I think that the preemptive pharmacogenetic testing, this is a test, the preemptive testing means the test before for the treatment plan in the healthy patients. So I think that the preemptive pharmacogenetic testing will be applied into the clinical implementation with the high technology such as next generation sequencing for whole exome sequencing and whole genome sequencing. And the data of the patients, like the genomic data of the patients, might be incorporated into the electronic medical record, and we can use the genetic data or genetic information of the patient to take care of them for the whole life. And so now in Thailand, the genomics and pharmacogenomics will drive our healthcare system. And we are now the phase to minimize and eradicate the adverse event for our Thai populations, especially for severe cutaneous adverse drug reactions. And I think that we, as a healthcare provider, we need to ready for the technology. So by summarizing my talk, so I think that the severe cutaneous adverse drug reaction can be preventable if the physician can test the biomarker before prescription. For the HLA pharmacogenetic testing, it can be categorized into 3 types. The first one is the specific biomarker, which is positive or negative, and this test is supported by National Health Security Office or SPSOC. And the second one is a HLA-B genotyping, which is reviews the HLA genotype for the patient, and also the HLA panels, which is include the HLA-A and HLA-B for taking care of the foreigner patients. For the HLA-B and the drugs associations has been confirmed and validated in Thai populations, such as HLA-B 1502 for carbamazepine and carbamazepine, and HLA-B 5701 for adacavir, HLA-B 5801 for allopurinol, HLA-B 1301 for Co-trimoxazole and Dapsol. And not just only for the genetics that the physician should be considered, but the physician should be considered for the non-genetic factor, such as in allopurinol, they should prescribe the allopurinol with lower dose, less than 100 milligrams a day, to prevent the scar, especially in the renal impairment patients. And not just only for the pharmacogenetic testing that's very important, but also the another tools that can help to prevent the scar incidents in our country, such as pharmacogenetic card, electronic medical record, and also pre and post counseling system. So lastly, I would like to acknowledge our contributions and support for my colleagues in Thailand and also international groups for the research study and also clinical implementations. I also take this opportunity to acknowledge all of my team and my grant for supporting me in pharmacogenomic research, and some of our findings can be translated to be the national policy screening, as I already talked to you today. And thank you for your attention. So if you need more information in any issues, please do not hesitate to contact me directly as provided information here. Thank you very much.